Hi, I'm Dr. Chris Seigel, Associate Professor of Urology at UCLA. I'd like to thank you for joining our webinar on active surveillance in men with prostate cancer. To start with a little bit about prostate cancer and its impact on men in this country. Prostate cancer is the most common non-skin cancer in men. It's the second leading cause of cancer-related death in men in this country, and it results in about 30,000 deaths in men every year. This number has been decreasing every year, luckily, thanks to the use of PSA screening. About 1 in 6 men born today will be diagnosed with prostate cancer at some point in their lifetime if current screening trends continue. There are some risk factors that are relevant for prostate cancer. Certainly age is one of them. As a man gets older, his risk of being diagnosed gets higher. And in fact, if you do autopsies on men in their 70s, almost 3/4 of them will have some evidence of prostate cancer. Most of those men, however, will not die of prostate cancer, which is important considering on who to treat. Race is also a very important risk factor for prostate cancer. African American men have about 50% higher incidence of prostate cancer and almost twice the mortality. So screening is very important in those men. There's some provocative data about the role of diet in prostate cancer. In general, things that are heart healthy are prostate cancer healthy. There are data that are interesting about Japanese men, for example. In Japan, the rate of prostate cancer detection is very low. But when you look at men who are born in Japan but moved to the US at a young age, their rates of prostate cancer are similar to the rest of the population. So something about the Western diet or environment might be a risk factor. Family history is also very relevant for prostate cancer detection. Men that have a first-degree male relative, a father or a brother, who have prostate cancer that was diagnosed before the age of 65 are at increased risk for prostate cancer themselves, 1.5 to 2 times the risk of prostate cancer. Because of the use of PSA screening, we've seen a stage shift of diagnosis in prostate cancer. We're finding prostate cancer at earlier stages and more treatable stages. On this slide, this represents the types of cancers that diagnosed over a period of time after PSA was introduced. In the late 1980s, you see there in the yellow, that's the number of men found where the prostate cancer was not palpable by rectal examination. You can see how that proportion grows over time to almost half of the men with prostate cancer being diagnosed at a non-palpable stage. The bright green bar are men that have a very advanced cancer where it's invaded out of the prostate or even locally into surrounding structures, and that number drops over time. So that's very promising for the treatment of prostate cancer. Next slide. The issue is that because so many men are carrying prostate cancers that don't kill them, and we're finding more early stage prostate cancers, do we have to treat all of these men in order to improve their lives? And this has been a problem that has been apparent in prostate cancer care for as long as doctors have been treating prostate cancer. It was first posed by Dr. Willett Whitmore, one of the founders of the field of what's known as urologic oncology. And he asked, is cure possible for those in whom it's necessary, and is it necessary for those whom it's possible? Next slide. If you have prostate cancer these days, there are many treatment options. This is often quite confusing. Today the options include surgery via either the robotic approach or an open approach, external beam radiation therapy. There's many variations on that as well. Brachytherapy, or the placement of seeds into the prostate that emit radioactivity. There are experimental options, including high-intensity focused ultrasound and cryotherapy. And then there's the role of active surveillance for prostate cancer, which is the focus of the talk today. When you look across the country at how it's being treated, prostate cancer there's a lot of variety in that. On this slide, you can see this is basically looking at the risk of spread of prostate cancer after treatment. This is a person with a low risk of that. This is a person with a high risk of that. And these are data from across the country showing that most men with low-risk cancers are being treated with surgery, seen in the blue, and that proportion decreases. And then with higher risks of high-risk cancers, actually are having a lot of treatment with hormone therapy, which is not curative. So there's a possibility that some of these men with a lower risk tumors are being overtreated with definitive therapy, and some of the men who could benefit the most from aggressive therapy are not getting a curative approach. Next slide. And the treatment you get is often dependent upon the doctor that you see. This is data from that same national registry. and each of these bars is a different site where prostate cancer is treated. And these numbers here are the risk of average risk in the group of men being treated. These are men that have very similar risk groups, 2.44 versus 2.48. But you can see here that in this center, about 80% of men are being treated with surgery. In this center, about 40% of men are being treated with brachytherapy. So who you see can really determine what kind of treatment you get. Next slide. One thing that's for certain about prostate cancer is that treatment of the cancer impacts a man's quality of life. And at UCLA, we were pioneers in the development of ways to accurately record the impact of treatment of prostate cancer on our patients' quality of life, and we track that. This is an example of how we do that over time. Basically, we give patients surveys after treatment, and they answer specific questions about sexual, urinary, and bowel function. When the score is at 100, it's perfect. 0 means terrible, and then we measure over time how they do, and we kind of create bar graphs. Next slide. This is men who had urinary function after surgery. It drops initially and recovers. And men who had radiation therapy, they stay about pretty stable, and the curves kind of join at about 2 years. Next slide. This is urinary bother after treatment. This shows how men who have treatment with radiation therapy or surgery differ in that regard. Men who had radiation have a lower score here, indicating more bother after treatment. This gets better over time and almost matches surgery at about 2 years. The slide we didn't see was sexual function, which drops precipitously after treatment with surgery and then gets very similar to radiation therapy after about 2 years. Next slide. There are attempts to minimize the role of these negative impacts on men after treatment. In surgery, we use now robotic technology to try to minimize the impact of this treatment on your sexual, urinary, or other health problems that can happen after surgery. Radiation therapy is also being modified to be more image-guided and to more accurately target the radiation to the prostate and avoid some of the side effects. However, we still have not been able to answer the question for our patients about, is cure necessary for all of our patients in whom it's possible? And this is where active surveillance as an approach to treatment can help shed light on that. Next slide. Active surveillance for prostate cancer is more than just watchful waiting, which is an older term. Watchful waiting was a situation in which a man was diagnosed with prostate cancer and then wouldn't receive any treatment until he had symptoms, bone pain, something like that, and then he got hormone treatment. With active surveillance, a man is followed very closely over time using PSA as a marker for tumor activity and regular tissue sampling via biopsy to see if the tumor changes in any way. And if there is a change in those parameters, the man is referred for definitive therapy with the radiation or surgery. Next slide. So who's a candidate for this approach? There are 7 large studies that have been published on active surveillance so far. In those studies, the criteria for active surveillance include men with what's called a low risk or maybe intermediate risk prostate cancer. That's partially defined by what's called their Gleason score. Gleason score is a measure of tumor aggressiveness. It's scored from 2 to 10, with 10 being most aggressive and 2 being least aggressive. So if your Gleason score is 6 or less, you're often a candidate for active surveillance. In some studies, Gleason 7 tumors are enrolled into these trials, especially in older patients. We look at your tumor markers, your PSA level. Usually most studies have a PSA of 10 or less as a criteria for entry. We look at your physical exam. If a nodule is felt in the prostate, we like to see it only covering 1/2 of the gland or less. We also look at measures of tumor volume, and this is varied by site, but basically the number of positive cores on the biopsy that diagnosed you, or the amount of tumor in any one core can be criteria for entry. And lifestyle is important too. Patients that have to be willing to return to clinic for regular checkups and perhaps biopsies on an annual basis. Next slide. So really, the protocols for active surveillance do vary by center, but they all involve regular PSA and prostate exams every 4 to 6 months, and a repeat prostate biopsy at a year or every other year. Many centers ask a patient to have a repeat biopsy before they enter active surveillance to make sure that they're not missing a more aggressive cancer or miss on the first biopsy. And patients come off of active surveillance when their PSA rises. Oftentimes we look at the doubling time of the PSA, or if the Gleason score on a repeat biopsy gets worse. If there's a change in the rectal exam, or if a patient just tires of the routine of surveillance. In most series, between 20 to 30% of men will come off of active surveillance at some point under this strategy and seek definitive management. The time range of that is often 2 or 3 years out. Next slide. So is this a safe strategy? Well, in most prostate cancer studies, we need at least 10 years of data to make definitive recommendations about safety, because prostate cancer generally is slowing and it takes a long time, thankfully, to cause mortality in men. The median follow-up of studies have been published so far is between 2 and 7 years. The data so far show that the risk of dying of prostate cancer is low, and the survival rates on active surveillance have been about 97 to 100% in terms of risk of dying of prostate cancer specifically. And to date, there's no evidence of increased risk of prostate cancer death if you wait on active surveillance and then seek treatment at a certain point in time. And the surgical cure rates, in fact, are quite similar to those published after men who have had immediate surgery. And those cure rates have ranged from 91 to 100% in most of these studies. But I would caution that those studies have short follow-up and are only 2 or 3 years out. So one of the questions about active surveillance is, can we make it safer and more secure for patients who choose it? And there are certainly ways that we think we can do that with the help of the latest in imaging technology. This slide shows a traditional prostate biopsy. And here you see the probe that's placed in the rectum. This is the prostate, which is numbed before the biopsy. And prostate cancer in ultrasound can appear as either a dark spot, a white spot, or even the same color as the prostate gland. And so using ultrasound technology, it's hard to see where the prostate is. Next slide. So what we end up doing is doing what's called a template-guided biopsy. We systematically take tissue samples across the prostate gland. What can happen, however, is that you can miss cancers because you can't see them. Large cancers are often detected because you're taking a systematic sample, but you can miss a small cancer or even a larger cancer if it happens to lie in between your biopsy tracts. Next cancer. So we think we can use MRI at UCLA to improve our ability to locate these cancers and track them over time. MRI stands for magnetic resonance imaging. It's a safe technology that relies on high-powered magnets to allow us to create images of tissue. There's no radiation involved. We can't use MRI for biopsy itself because we can't put metal in the same room where there's an MRI machine. What we can do, however, is use MRI to locate abnormalities in the prostate and help merge that image with the real-time ultrasound image. And I would say that in general, there are MRI centers around the country that are good at this. If you're watching this webinar and you're not in Los Angeles, look for a center that does prostate MRI specifically, has a team dedicated to that because not all MRIs are alike. At UCLA, at least, we meet regularly with our radiologists and pathologists, and we go over every prostate that's removed and correlate the abnormalities in that actual prostate with what we see on the image and what's seen on the slides. And that helps us to make our readings more accurate. So this is an example. This is the MRI image of the prostate gland here, and then in real time with the probe in the patient, we can match it to what we see on the ultrasound here and use that to guide a biopsy. Next slide. This is an example of what the machine looks like. There's a piece of technology that lets the probe tell the computer where it is in space and allows that to match with what's seen in 3 dimensions in the MRI. Next slide. So in that way, what we can do is, if this lesion is seen in MRI, we can take a directed biopsy right into it and not miss it. We can also, if this is the target lesion and the person's on active surveillance, keep hitting the same lesion over time so we can watch it specifically for changes. In many studies on patients on active surveillance, the repeat biopsies on active surveillance show no cancer. And that may be because the cancer is small and the target is being missed because of the systematic approach. With a approach using MRI, you can keep that image and replay it when you're doing an ultrasound on the patient and find that same location again. This is an example of how that works. The system provides a target for us to show us on the MRI where the abnormality is that wasn't visible on ultrasound. This orange line is the needle going right into the target on both images. And then we store this image and we'll reuse it for the next biopsy the patient has so we can hit the same spot. Next slide. What's also important about choosing a treatment for prostate cancer is personalizing the choice. there's no one right answer for a man with prostate cancer. And we at UCLA believe that we can use intelligent agents to help a man make a better choice that's consistent with his personal values and the evidence about the risks that he faces in any given decision about prostate cancer. Next slide. We're using technology from a company called WiserCare to allow patients to make these decisions. What this software does is allows you to enter in your PSA, your Gleason score, and other things that determine your risk for death and other side effects. And it also does an interview where you go through the different side effects of treatment and observation, and you get to express your preferences through a simple choice exercise. Our patients then are seen in clinic with a report that suggests their top 1, 2, and 3 evidence-based choices consistent with their preferences and the evidence around their disease, and also tells us what their preferences are. So we make sure we address what's specifically important to that particular man. And this has been a very popular component of our clinics. Next slide. I want to conclude on a few issues about lifestyle changes in active surveillance. There are some interesting data that changing your lifestyle can impact the growth of prostate cancer. This is a study out of UCSF in which 93 men who had prostate cancer and were on active surveillance were randomized to either very healthy diet and exercise or just usual care. And the men got lots of tofu, fish oil, low-fat diet. Next slide. They were encouraged to do moderate aerobic exercise, 30 minutes of walking a day for 6 days a week. They also engaged in stress management, yoga. They were taught breathing techniques. And what they found was, in this small study, that in this group, in the 6 of the patients who were in the control group and just had usual care ended up getting active treatment for prostate cancer, but no one in the experimental arm that got the intervention did. And there was a significant difference in the PSA levels in the 2 groups in favor of the diet and exercise group. What I find is most provocative is that if you took blood from the men who did the exercise and stress management and dietary intervention and try to grow prostate cancer cells in a laboratory in that serum compared to men who had usual care, the prostate cancer cells grew much less fast in the men who had the intervention. So there's something biological happening, we think, and this lends support to our belief that things that are heart healthy are prostate cancer healthy. And diet and exercise can be a healthy adjunct to men on active surveillance and can also decrease the risk of dying of cardiovascular disease, one of the most common causes of death in men with prostate cancer. Next slide. There are on the internet lots of solicitations for men with prostate cancer to try different herbal medications and alternative therapies. We're certainly open to that at UCLA as long as there's some evidence behind it. There was a very famous case in California several years ago where a herbal medicine called PC-Spez was being sold as a Chinese supplement. It was analyzed and found to contain estrogen, which does reduce your PSA, but was an older treatment for prostate cancer that resulted in heart attacks and blood clots. So this was taken off the market, obviously. There are lots of advertisements for saw palmetto or Pygeum africanum that are sold to promote prostate health. Those have no role in prostate cancer prevention or treatment. They are sometimes sold for the reduction in the size of the gland to help a man empty his bladder more effectively. We do think that an integrated approach with diet, exercise, and close monitoring could be a great solution, however. So in conclusion, active surveillance is a safe, evidence-based strategy to manage prostate cancer if done in a systematic fashion. It does allow a man to avoid the downside risks of treatment of prostate cancer while preserving his option to seek cure if it seems necessary at some point. And imaging technology can make active surveillance even safer as a strategy for a man with prostate cancer. Finally, prostate cancer treatments need to be individualized based on a man's personal preferences and goals. And with that, we'll take some questions. Thanks. All right. So how can I be sure that my cancer risk is low? Well, prostate cancer is usually stratified into low, medium, and high risk. And that's based on your Gleason score and your PSA and the prostate exam result. Low risk means your Gleason score is 6 or below, your PSA is 10 or below, and there's nothing that's palpable on the prostate, or if it's palpable, it's on one half of the gland. And sometimes on an initial biopsy, only a part of the tumor is caught, as I mentioned on the ultrasound. So we think that before you begin active surveillance, a repeat imaging with MRI and perhaps a repeat biopsy is indicated to make sure that a more aggressive tumor is not being missed. What are the risks of active surveillance for prostate cancer? Well, certainly there is the downside being a little bit of anxiety in some patients. Some men aren't comfortable with the idea of watching and waiting with a cancer. So that's why we talk about stress reduction techniques, and we try to provide reassurance with regular biopsies and PSA testing. The biggest risk men are worried about is that the cancer would spread beyond the confines of the prostate gland and result in death, obviously. That has not been a major concern in most of the studies to date. There are really only a handful of deaths reported in these studies. Some of those are in patients who refused treatment when there was an indication for treatment. In general, it's a very rare event. I should mention there was one data point about a data model that was produced to look at the risk of delayed treatment in men with prostate cancer that suggested that given today's data, there's perhaps a 1% increased risk in death in men who seek treatment after prostate cancer, after active surveillance on prostate cancer compared to those that seek immediate care. Can I prevent prostate cancer? Well, in general, most of the risk factors for prostate cancer aren't modifiable: race, age, family risk. Diet may be something that a person can do, especially in terms of things that are heart healthy, with low-fat diet, exercise, lots of fruits and vegetables. It's not too complicated in that regard. There are data to support the role of medicines for benign growth of the prostate. One is called finasteride, one is called dutasteride. Those have been shown to reduce your risk for prostate cancer as well, but the FDA did not approve those medications for that purpose because in the patients who had a reduced risk for prostate cancer, there were some higher Gleason scores found in those patients. So those data are a little bit gray, and the FDA didn't approve that. Have more men opted to do active surveillance over having surgery or another treatment? It is an increasing strategy, and certainly we have over 500 men at UCLA on active surveillance right now. I'd say that we're seeing a pendulum shift over towards more active surveillance, especially as men are more educated about what it means to have prostate cancer that's low risk. So I think we'll see it as a more popular strategy over time. How do you know when to stop active surveillance? This is an important question. As I mentioned, some centers will look at the PSA and the rate of change of PSA. Some centers don't look at that because PSA can rise for a variety of reasons, including benign growth of tissue. One way to address that is to use the medicines for benign growth like finasteride or dutasteride to stop that benign tissue from growing so the PSA signal is more pure. The other reasons to seek treatment after being on active surveillance are an increase in your Gleason score. And this is why a repeat biopsy is indicated at a year and perhaps yearly afterwards or every other year. So those are the two biggest risk factors, the two biggest triggers for going off active surveillance. It's somewhat individualized, but that's the general idea. What should I expect during active surveillance? You should expect regular contact with your urologist every 4 to 6 months in terms of a physical exam and blood tests. And you should expect to get a biopsy at a year out after the initial decision was made to go into active surveillance, and then every year or every other year thereafter. That can be stopped usually when a man is over 75. Sometimes centers follow patients with just PSA alone. I'm afraid that just doing active surveillance might make me really anxious. Can I do anything to make it easier? Well, I think part of that answer is talking to men who are on active surveillance and educating yourself about how they deal with it. I think that stress management, meditation, yoga, exercise, those are things that can help reduce your risk. I think reading a bit about it and understanding the data about its safety is important so you can reassure yourself. It's also very important that your spouse is on board. This is called a couples disease because the impact of treatment often affects the spouse. So having a supportive spouse is also very important, and having her or him educated about that is also critical. Are there any clinical trials for prostate cancer and active surveillance? Right now at UCLA we have a trial that's involving imaging that's NCI funded. We also keep all of our patients on active surveillance on a registry so we can follow their outcomes. The National Cancer Institute of Canada is also sponsoring a randomized trial with some sites accruing in the US, and there's a United Kingdom randomized trial about active surveillance versus active treatment. A few more questions? Okay. All right. Well, this is a question from a patient with a low-risk prostate cancer, and the patient's curious about what to do about that. A Gleason 6 score and a PSA of under 5 with a normal rectal exam, and he's a fairly healthy man. So this is a very common dilemma. I think that for this type of patient with a low-risk prostate cancer who's 66 years old and very healthy, who has definitely more than a 10-year life expectancy, all the options are on the table. That would be surgery, often using robotic technology, radiation therapy, or active surveillance. And this is where we do feel that talking to the patient about the importance of sexual function, the importance of their anxiety about untreated cancer, the importance of their worries about overactive bladder, and how important their small risk of dying of this kind of cancer is for them. We use technology to help them understand these risks and to sort out the differences. So really all these options are on the table for a man in this situation, and active surveillance is certainly one of them. I would recommend getting if you do choose active surveillance, to get a study entry protocol repeat biopsy with MRI guidance if possible, to make sure that you're not missing anything elsewhere in the prostate gland. And if that's okay, I think active surveillance is certainly a safe option here. Okay, thank you for attending today's webinar.